The first patient treated with Panhematin, this was in 1970 at the National Institutes of Health in Building 10, the main clinical center of the NIH. A woman with acute intermittent porphyria, very, very severe disease. She had had the acute intermittent porphyria for a number of years. She had been in the hospital there for some time, had unfortunately developed renal failure, was respirator dependent, as is sometimes the case, unfortunately, and was really desperately ill. And we had been doing studies over the past few years and had the concept, and I would say the concept had been pretty well established by then, that a small but critical so-called regulatory heme pool in liver cells was important in the repression of the first enzyme of that pathway called ALA synthase 1, delta aminolevulinic acid synthase 1. And it turns out that upregulation of that enzyme is the biochemical hallmark and pretty much the requirement in order to have active porphyria with symptoms and so on. And so we had these data from other models, from animal models and so on, and had a very sick patient, and we said it's time to see whether we can find any evidence of benefit of giving intravenous heme to human subjects, human patients with acute intermittent porphyria.
25 years ago, we didn't have any treatments. You know, the only treatments was really liver transplantation. But nowadays, there are treatments for them. And it is just to see that transition and some things you never thought about, that you would make it this far and you'd see essentially ways to change people's lives, to help them live a more normal life, and just to get out and be active is fun to see. It really is.
Well, there's certainly mysteries to uncover, but certainly since the 1970s, a lot has been learned. We didn't really, back in the 1970s, we were beginning to identify what enzymes were altered in the different porphyrias. After that, a lot of the work had to do with identifying the mutations in the genes for those enzymes that were found in the different porphyrias. And as I mentioned, there have been a number of new treatments that have been developed more recently.
We've made steady advances over the years in the porphyrias. That being said, intravenous heme has proven to be the most helpful treatment. There are some other treatments. Other things that have changed since, say, the mid-1960s is that we no longer use as many of the highly porphyrogenic, highly dangerous drugs as we did back then. Among these are particularly the barbiturates, phenobarbital and other things like that, that led to the development of either initial attacks or recurrent attacks of acute porphyria. So some of it has been the advancement in the use of newer pharmaceuticals that are less porphyrogenic. The other thing that has clearly improved is our ability to diagnose the disease, although unfortunately in the US it's still about 15 years that go by from the time of first symptoms to the time of a proper diagnosis, and we'd like to shorten that length of time much further than we have been able to so far. I guess the other really big advance has been the idea, the development, and the approval of givosiran as another way to markedly downregulate this gene that is the hallmark of acute porphyric attacks, ALA synthase 1.